Hi, guys, and welcome back to Hygiene Elevated Conversations and Innovations. It's me, your host, Nicole, and I'm here with Shelley Brown, and we're super thankful that she's popped on with us today to talk about a really exciting topic that everyone's always confused about. So we're really ready for that. So, hi, Shelley, welcome.
Hello, and thank you for having me on about this very confusing topic. I agree with you.
Well, I know you've been on the podcast before, and you've answered all of our normal staple questions, so we won't, get back into that. We'll kind of jump right into things today. So, staging and grading, that's what we're going to be talking about. And I know as a new grad that's worked with people in all stages of their career as a hygienist, everyone kind of struggles with it still. It's not a black and white subject, and it's not something that we all just get. It all just clicks. Or the other, we have the same thoughts on it. So this is something that I think everybody could always use a refresher on. And the one question I do have about you, Shelley, in case someone hasn't listened to any of the previous episodes that we've had you on, is how did you get into instructing and what led you into teaching for hygiene?
Yeah. So even in dental hygiene school, I kind of was like, "Ooh, I think I'd love to be a teacher." I tutored a lot of like my fellow um classmates, and I was like, "I just really love making these hard things more simple." And so I always knew I wanted to get into education. So essentially the school where I went to school, I kind of said, "Hey, if you ever need like a teacher." And I got my foot in the door first through being a clinical educator. That's where most people start in the clinical setting. And then usually as you have like earned your rights in that setting, then they're like, okay, you're working great here. Maybe we could move you into didactic. So usually that's like the path that most people go. And so now I teach 7 of the didactic courses where I work at the Utah College of Dental Hygiene in Orem.
Wow, that's amazing. And honestly, it takes a special person to be a teacher because most of the time people don't appreciate, honestly, teachers in general. And it takes a special heart to do that. So I'm really glad that you are an incredible teacher. I know you were one of Joffrey's teachers, and she has nothing but sang your praises of how wonderful you are. And so I'm excited to learn from you myself. So let's talk about
Agreed.
staging and grading. Can you give us a little bit of background? I know this is a newer, source of diagnosing perio. So can you kind of talk to us about a little bit about history, when it started, and kind of how you learned it?
Yeah. So I first obviously learned about it in CE courses, just like everyone else. And I probably went to 3 or 4 of CE courses on the AAP classifications. And I was like, I do not know what these are because I had kind of taken them out of my clinical practice. Like when I was in hygiene school at that time, it was the 1999 version. And it was just like you chose a Roman numeral. Essentially, it was like one was chronic and one was aggressive periodontitis, and you would choose like a Roman numeral in hygiene school. And so I more focused on my dental hygiene diagnosis and did not so much focus on my AAP classification. So I was like, what changed? I don't even know. Is it the 88 classifications that changed? What are the AAP classifications? I don't know what those are. Taking a step back even farther, in 1989, there was a version that came out and just said like juvenile periodontitis, adult periodontitis. So when I was a hygiene assistant, clear back in the day, the hygienist I worked for, I would put her notes in and she would tell me that. She would say, put JP or AP or whatever it might have been. And those were the 1989 version. And I was working with that hygienist in 2005. And the new ones in the 1999 version had come out many years before that. So these changes, when they are made, they take like 10 years for people to implement them because, well, when they first came out, they weren't in the textbook. So we're like, are they going to be on boards? We don't know. And so finally, once they were in a textbook, then we could finally like implement them into clinics. And that has taken a long time for educational facilities to do. And so that's why it just has not gone mainstream quite yet. And that's why there's still continual education on what they are and why do we even implement them. Personally, I did not learn how to really use them until I had to teach about it. Right? That's like if you really want to learn something, you like be the teacher because then you're like, I have to know my stuff. So I first started teaching these with my master's degree, 2019. They had just come out, and I was like, nobody knows what these are. I don't know what they are. So I chose my capstone project to be teaching the AAP classification. And I kind of had to do a little study to see if what I taught kind of was retained with my group of students. And so I had to dive into the AAP classification releasings and documents, which are like, it's an easy weekend read. It's like 500 pages of very in depth research. And they put a lot of work and effort into those. And then after that, the perio course came up where I was teaching, and I was like, can I please teach that class? Because I feel like my perio course in hygiene school was not great. I feel like I had to do a lot of self-study, and I was like, I don't know like what's happening here. So I was like, I really want to teach that course so that I can be like, in the know of what's happening in the perio world. So that's a little bit of my background of how I got into teaching the AAP classifications. And yeah, I have to take that 500-page document and make it very tiny and very doable in the 30 seconds that we have as dental hygienists, right?
Yes, absolutely. It is. It is. It's a lot of information, a lot of moving things around, a lot of moving pieces to find one thing in the small amount of time that we have with every single patient, and just understanding that it is crucial. So that's amazing, though. I didn't realize that you had done that with your capstone, and like so you really took a passion of wanting to understand this and teach it to others, and
hmm
that's incredible. So that's really really cool. So I assume that you have a pretty good handle on this.
I think I do, but then sometimes I'm like, wait a second. Somebody
It,
asks me a question. I'm like, ooh, that's a good one. Let's solve that together because there's always some gray areas, right?
Yes. No, I had that with the when I was studying for boards, there was a couple, they give you those case studies and questions, and there was a couple that I was like, "I'm sorry, this just doesn't make sense to me." And I would brought it to my instructor who taught perio, and she's like, "I don't know either." Like, and then we look at the answer together and try and almost backtrack it. But, in
Mhm,
practice, you don't have the correct answer to backtrack it from. So you
mhm,
don't get to have that opportunity of being like, "Oh, well, this is why I was right or wrong." You make that decision, that's the decision. Okay, well, can
mhm.
you tell us about the AAP staging and grading system and break it down the best you can for us?
Yeah, definitely. So I will say that even though I feel like I know how to make it more simplified, I think it's still a little difficult. I loved like the Roman numeral answer. That was easy. But it's pretty straightforward for perio, honestly. It's pretty easy to understand. But sometimes when you get to like the health section, you're like, wait, there is health here. There is some gingivitis. Like, what am I putting for my AAP classification? That is a bit confusing. And I'll just tell you right now that I personally combine my dental hygiene diagnosis slash AAP classification line on my clinic notes, and they're just kind of mushed together. So, whatever you're currently putting as your dental hygiene diagnosis, just put AAP in front of it for health and gingivitis and call it both. Okay, that's the easy version, the easy explanation. I would include in that it's a great idea as well to put they're asking us to put more of a description. So, for example, if you're talking about gingivitis, you should put why they have gingivitis. So it would be AAP classification slash dental hygiene diagnosis, gingivitis. Like what level? Obviously, that's what we usually put moderate, slight, or severe. So we know our code. And then why? Is it biofilm induced? Is there a viral infection going on? So put the reasons why. The new thing that we have with our AAP classifications is health. When the 1999 version came out, there was this Roman numeral 1 through 7, and it started with gingivitis. So there was no health. So we were like, wait, what is the AAB classification for health? Do we just write health? And yeah, that's exactly what we do. There are versions of health, though, that are out there. You've probably seen this patient who's like the unicorn patient, all threes and below, no bone loss, right? Looking beautiful and perfect. There's also a version of health where there is still bone loss, but they have great gingiva. They've never had an active microbial infection. And so, can those people still be health? Oh, yeah, they are. But maybe let's put a description as to why they might have this bone loss. So, our AAP classification in that case would be generalized health with generalized bone loss due to ortho, due to bruxism, whatever it might be, those patients can still be prophies. And those patients, if they've never had an active microbial infection, will never need a stage and grade, is what we talk about here in just a minute. And never need a stage and grade. There's also another version of health, and that version of health is maybe a patient who had periodontitis and now they're in a healthy state. We can call those patients health, but we still have to give those patients what's called a stage and a grade. So there's a few variations of health in there that we might see with our patients. The biggest change that came from these new AAP classifications was the periodontitis section, as well as a new implant section, and then health, which I just talked to you about. Before we dive into periodontitis, can I go into, I just want to talk to you real quick about the implants. So if you
Yes,
have a
please.
patient, yeah, who has an implant, I'm doing all this from memory, by the way. So I'm trying, I might backtrack a few times here and there. So if you have a patient who has an implant, you need to put an AAP classification or add that to your dental hygiene diagnosis, what that implant looks like. It could either be health, which is, you know what health looks like, right? It could be implant mucositis, um, or it could be, which is just more like the gingivitis version, just more like redness, inflammation, but there's no bone loss. Or if you do see bone loss around it, then you would need to describe what's happening with that implant as well. So important to also add in implants now to our dental hygiene diagnosis slash AAP classification. Okay.
Can I ask you a question about the implant thing
Yeah.
while we're on that? Where I kind of get not even really confused on that, but I've worked in perio as an assistant for many years, and what I have learned and been told is that it is normal for implants to probe upwards of 5, 6 millimeters, and that can still be considered health. So when somebody's looking at an implant, and it is, they have, they're healthy, they're doing a good job, they're not having any bone loss or anything, but it's still probing fives and sixes. What is the best way for someone to determine that, obviously they should know that it's health, but with those probings alone, does that change anything?
Yeah, I love that you brought that up because they will be a little bit deeper because our junctional epithelium no longer exists. It's a little bit different, right? So yeah, that the pocket depth does not always indicate health or disease around an implant. It's going to be different from a natural tooth. So in that case, we're looking for redness if we're on the gingivitis version, and then radiographically, we're looking for bone loss from 1 year to the next year. There could be an indicator of a probe depth, possibly, but mostly we're looking at the tissues and we're looking at the bone. We're looking for any exudate. Those type of things are going to be more of your cues versus just your probe depths alone.
Awesome. Thank you for that explanation, because that's something that I know sometimes I get like confused about.
Yeah, that is a little tricky when we're told a 5 is perio always,
Right.
and maybe that does not apply to implants for sure.
Exactly. Okay.
So the bigger change, periodontitis. We should go into that one.
The big guy.
Okay, so this one, periodontitis, is the one that we are now staging and grading. And we do not do this with health, when with intact bone. You will still stage and grade if they return to health after having periodontitis. I want to clear that up because when it first came out, my colleague Jessica Atkinson, she was staging and grading everybody. She was like, I think I know what this means, but everybody with health and gingivitis, she was giving them a stage and grade. And you do not need to give a stage and grade to anybody unless they have an active periodontal microbial infection causing periodontitis as the diagnosis. Okay. So keep that nugget in the back of your mind. So, stage, we're going to give our patient a stage from 1 to 4. Okay. And I'm just going to tell you already that you already know these patients. They did not change what initial, moderate, or severe or very severe periodontitis looks like. It's going to be the same as what you are already doing it, but along with that verbiage, we're going to put a number 1, 2, 3, or 4. So mild is 1 or slight, and then moderate is 2, severe is 3, and the documents say very severe is 4, but a lot of people they kind of chunk that together in the actual like table. So I encourage you to go and look at the periodontal tables, perio.org. They have these little grade tables you should print off and collaborate with your dentist, because your dentist is ultimately actually responsible for making the dental hygiene diagnosis slash AAP classification, depending on where you're located in the world. Okay. So, hygienists are really invested in this. And most of the time, the dentists don't really know that there was a change. So, we're really having to guide them and educate them on what this means, because they are ultimately responsible. So staging essentially says, how bad is it, doc? How severe is it? So we took a model from cancer and we applied it to this disease, this condition. So I had a family member who texted and said, I have cancer, I have a tumor in my hip, and we're going to see what stage it's at and what grade it is. So we have to do a little biopsy. And what that means is how severe it is and advanced it is. And at this rate of growth is what's going to happen based on that rate of growth. So that's what we did. We took this similar model and applied it to periodontitis. So I just want you to recognize, without maybe even looking at a table, we're on a podcast here, right? What do you consider slight periodontitis? Just think about it. Whatever that is. Maybe
So
you tell me, Nicole. What do you think it is?
yeah, well, in my mind, like mild or slight, is kind of where you're getting to your lower. I guess you've got moderate bone loss. You're seeing like 1 to maybe 3 millimeters of bone loss, nothing major. Still horizontal. You're not seeing any vertical defects there, and you're not having major pockets, but you do still have some deeper pockets.
Mhm.
But it's not to a, I guess, super severe part
Yeah,
yet.
early stages. I love
Yeah,
it. I might tweak your terminology maybe just a little bit, because you said I might
please,
see moderate bone loss, but we're gonna see only slight. We're gonna get to moderate
slight.
here in just a
Okay.
moment. Slight. So this is the patient where you have fours, you have bleeding, maybe one little baby 5 that maybe has more like gingival inflammation, right? And you look at the radiographs and you go, maybe. And there's a ton of
Mhm.
calculus, and you realize this is going to take you a lot longer than just like a prophy. And you can maybe see some crestal, maybe a tiny little bit of cupping. You're vacillating. Should this be a gingivitis code? Should this be perio code? That early stage, that's our moderate. Okay, those are the ones I hate to actually diagnose, because I'm like, I know this is going to be more of a bigger treatment plan than gingivitis. So sometimes that's hard, I think, for a hygienist to like pull that trigger and make that call to slight. So that's what those patients look like. Then we have our moderate patients, just like they've always been before. You look at the radiographs and there's bone loss. You're just like, I see it. It's between 15 to 33%, the most severe area. And then our pocket depths they're inching up there a little more. There's more 4s and there's quite a few more 5s. Okay, that's where we're looking. Just a reminder, a 5 could mean many things. Okay, a 5 could mean gingivitis, it could be slight, it could be moderate. So, you always have to just ask yourself a question when you're looking at your probe depths and when you're taking a probe depth, where is my junctional epithelium? Where is it? It's supposed to be at the CEJ. And you have to ask yourself, has this migrated apically? Then I have periodontitis. Okay. So your gingival margin might be swollen and inflamed, and you might not have any loss of that junctional epithelium. We're just using our best clinical judgment at this point. Someday, hopeful that we can get more accurate readings of where that junctional epithelium is exactly around the tooth. That's my hope for someday. But for right now, we're using our little probes. Okay. So our moderate is 15 to 33% bone loss, some 4s and 5s and in there. Our severe stage 3, what we call it, is where we have 33% bone loss and maybe beyond. You've seen severe bone loss before. It's pretty severe. Anything 34% and beyond. So it's like, Shelley, what's the difference between 33 and 34? Use your best clinical judgment. Like you already know. So, and this patient has not lost maybe any teeth yet from periodontitis, up to 4 teeth from periodontitis. So The difference between stage 3 and stage 4, actually the criteria are the same. So when we look at bone loss, the table says 34% and beyond to the middle third of the root. And it also says the same amount of like probe depths and clinical attachment loss. They're the same. But what the difference is when we call it stage 3 versus stage 4 is if stage 3 will be those patients. I want you to envision this patient for a second. Stage 4 is these patients who have lost 5 or more teeth already from periodontitis, not from wisdom teeth extractions, not from a root canal gone bad, but they're like, my tooth became wiggly. I had to have it pulled out, or I pulled it out myself. I've had patients like that before, right? So that's the big difference between 3 and 4 is we've already lost teeth due to periodontitis. So have you seen patients like that? Have you seen them often, Nicole?
Yes, and I'm actually glad that you said that because I asked on Instagram if anybody had specific questions for you, and that was a
Mhm.
question that came up was this person felt it gets a little bit tricky when you're taking into consideration extractions due to ortho or decayed teeth. And I guess also when we're kind of looking at, say, we're getting a new patient and patients in partials, they only have canine to canine dentition. How, when we look at them and say, hey, did you lose this from periodontitis? They probably don't know what we're talking about. So, what's a good way in that situation to determine whether or not it was periodontitis that caused those extractions?
Yeah, we can ask, did you have what's called periodontitis? So you could definitely ask them. Or you could just use your best clinical judgment. If you're like, all these are flopping in the wind, I know what happened back here. So
Right.
I would just say, yeah, they probably lost those from periodontitis, to be
Yeah.
honest. So you just use your best clinical judgment. You don't really have to be like dive in and spend an hour asking them and trying to find out the history. Just like
Where
make
did
a
one go? Where did
yeah,
two go?
yeah, a 10-second decision on what you think,
Yeah.
where you think that they land. So that's essentially staging. So I'd encourage you to, continue to put slight or initial, moderate, severe to very severe, but add in a number, stage 1, 2, 3, or 4. Your AAP classification is supposed to be just the most severe area. So we would never give two numbers. We would never say generalized stage 2 with localized stage 4. We would never say that. Okay. In this, that's more for your dental hygiene diagnosis. Our AAP, we're going to give one only. It will be the most severe. And if that condition is most severe only in one area, we'll just put localized stage 4. My AAP classification would be localized stage 4. And you don't have to even talk about the rest stage wise. We just want to know where that they have stage 4. It's localized. That's concerning. And then we can get more descriptive in our dental hygiene diagnosis.
Okay. So if
So,
we're
are there any
looking
questions up to
at,
this point? If not, we can go to grade.
I did have a quick question though. So if we're looking at, like, say you were talking about having a localized stage 4, and but I feel like with stage 3 and stage 4 being pretty close, but just being determined like a lot of times on how many teeth are missing. So I feel like a lot of my patients end up being stage 3. Like I would say majority, I feel like of my patients usually are stage 3, unless they are missing, 5+ teeth. So how is it possible to have a localized area of 4 if maybe the person isn't missing that many teeth, or would they have to be missing that amount of teeth to have a localized 4? Does that make sense?
Yeah, I totally get what you're saying. That scenario would be very unique, I think, to only have severe period in one area, but the rest look good,
Right.
or like that. I think that one would be a little more tricky, but so it would probably be more localized, like stage 3. But I'm sure some patient out there could pull out a localized stage 4 where there's only like a few teeth that maybe got damaged. I mean, it would have to be 5, in one area. That might be weird, but I wouldn't put it past a patient to present with something like that. But yeah, if it's only localized stage 3 up here, because they have that bone loss in one area, but everywhere else is slight, then we would just go with the most severe area.
Gotcha.
Good
Yeah, I
question.
know. Some of our patients bring us some very wild things.
Mhm.
Okay, well,
They
let's
do.
hit grading. Tell us about that.
Okay, so what grading is essentially, you have to ask yourself, at this rate of loss, will my patient be able to keep their teeth? And I don't say this to patients, okay? They're like, "What?" Like, that would be a weird thing to say. You're gonna outlast your teeth and live longer than your teeth." I would never say that, but that's essentially what we're trying to ask ourselves. So before I even teach you how to do grade, I want you to think to yourself, just use your best clinical judgment here. If you have a 15-year-old and they have 20% bone loss, are we concerned at that rate of loss that they're going to lose their teeth before they need them? No longer need them? What do you think? Is
I
age
mean, I feel like
15, 20%?
fif yeah, 20% at 15 seems a little extreme, even if that's ortho-induced.
Yeah. It's definitely concerning to me. So we would give them a grade of probably C because we're like, ooh, at this rate, you have an active bacterial infection, not from ortho, but an active bacterial infection at this young age. I don't know if you're going to be able to keep your teeth. So we're looking at potential dentures if we continue to lose bone at this rate. And so I don't always do the math. I don't always do all the things that the table tells me to do because I know at this point to use my best clinical judgment. So grading essentially is, the progression, okay, of what's happening in the patient's mouth. Let's say another example. You have a 90-year-old patient. They have 10% bone loss. Are you concerned that their teeth are going to last them for their lifetime at that rate of loss?
No,
No.
that's
If
good.
they lived yeah, if they lived to 180 and only got to 20%, they'd be keeping their teeth for their lifetime, right? So that's like essentially how we, pick a grade for a patient is we think for their age is at this rate of loss, at this severe periodontitis that they have, are they going to be able to keep their teeth? So that's exactly what this table has you look at. They're going to have you give a grade from A, B, or C. And A is essentially they're not losing too much bone at this point. So if we get them stabilized for their age and everything's looking good, they're not progressing, like they probably would be state or grade A. Okay, grade A. But if they are still smoking a pack a day, they already have so much bone loss, they're 30 years old. At this rate, I don't know if your teeth are going to last. We might have to look at dentures because you're losing bone at a really progressive rate. And so that table actually has you do some math. I don't ever love to do the math, but you can use your best clinical judgment here. Essentially, what the math is you take the greatest amount of bone on the radiographs. You look around and you're like, okay, right here, I've got 20% bone loss. And then I push the little divide button in your calculator, divide by their age. Let's say they're 20 and we get 1, right? 20 divided by 20 is 1. And actually that puts us, it gives us criteria on the tables. A criteria of 1 actually puts us in the C category. And so you definitely could go through and do the math. You could practice it a few times, but it's also just easier just to think for yourself clinically, like this amount of bone loss at this rate, am I concerned? So they get an A, B, or a C based on that. Some other criteria that might affect that is if they smoke 10 or more cigarettes per day, they're instantly at a C. If they smoke 10 at all, 10 or less, 9 or less, 9 to 1, then they're at a B. And if they don't smoke, they'd be in an A. Also, diabetes helps us to know if we're concerned or not. So if they don't have diabetes at all, they're at an A. If they have diabetes, HbA1c under a certain number, they're a B, and above a certain number that they're a C. And I always get asked about the smoking question. Is it if they vape as well? And it's just currently at this point, the grade is modified if they smoke like cigars, cigarettes, the tobacco products with the nicotine. It's not if they vape, it's not if they chew. Obviously, we know that those affect the periodontium, but it's not going to affect the grade at this point. So I've heard that that's coming through the grapevine, but currently it's not a grade modifier.
Okay, gotcha. That was really helpful. I was always kind of told, you start at B and then you take those modifying factors and you kind of adjust your thoughts from there. So I think that was really, really well explained. So thank you so much for that. Now, as we're just wrapping up, I really just kind of wanted to know. I feel like for me personally, case studies were always really helpful to practice this diagnosis because, like we were talking about in the beginning, you get that instant answer of yeah, you were right about that, according to what they think. And so, what's a really good place to find resources that people can practice these kinds of staging and grading and different diagnoses?
Mhm. I do know that a lot of educators send their students to like Colgate to practice some of the AAP classifications because they do have some case studies on there. And I have heard that like sometimes, they feel a little bit different about what some of the answers are based on stage and grade. And so, gosh, that's one tricky thing about hygiene is sometimes it's hard to be a little bit calibrated. I feel like
Mhm.
it's a little easy to like get more descriptive than another hygienist, type thing. So I think the easiest way to practice is meet with your team. If you're a lone hygienist, like you could have one of your hygiene buds come along and take a peek with you too, but maybe even just your dentist, like you and your dentist obviously need to get together and decide the AAB classifications, what they are, and just use some of your existing patients and be like, hey, these are the tables. How much bone loss is there? What are the probe depths? And based on that, what do we think? Let's calibrate what we think the stage is here. Cause I feel like every dentist diagnosis is a little different as well. Right. And so I think that chatting with them about it and then pick a grade as well and do like a few case studies in a staff meeting. And because your front desk also needs to be calibrated to know that like this should be written in the clinical notes because it has to go to insurance as well because they're looking for the AAP classification. And so you can practice on your own on some of the case studies online on Colgate. And then I would encourage you to practice with your own staff having some type of training. If you get a hold of the materials and you create a training for your practice, you're going to learn it much better if you have to train others. So do something like that for your practice.
Yeah, I think that's a really great idea. I know at my practice, like I was saying, I work at a larger practice, but me and the girls I work with, if we have like a concern or like a question about one patient, we're all really great where we'll go and be like, "Hey, do you mind stepping in and taking a look at this?" Even if the patient's there sometimes, and be like, "What are your thoughts on this?" Like, so it is really nice to be able to not just calibrate your team, but have the support of others to be able to bounce ideas off of, to be able to, try and make sure that you're feeling confident with what you're deciding that the next steps need to be for these patients. So I think that's a fantastic way to practice, get into, a sync of what you're feeling like and really start to feel comfortable with these different stages and grades. Well,
Yeah.
Shelley, I won't keep you too much longer because you have just been so amazing. You were just like laid it all out for us in such a beautiful way. So thank you so, so much for coming on today. I think this is going to be an incredibly helpful episode for so many people, new grads to seasoned hygienists alike. And we are so thankful for your time.
Thanks for having me. If there are any follow-up questions, you are welcome to find me at Shelley the Hygienist on Instagram. Message me there. I'd love to connect.
All right. Thank you.
Thanks.